Good afternoon. Welcome to all. I am Dr. S. Jayaraman, Secretary, IMA-AMS. Welcome to this monthly webinar. Today's webinar is mainly focused on to commemorate the World Blood Donor Day and International Anti-Drug Abuse Day commemoration. So we're going to have the wonderful speakers and moderators. Meeting start. This is the program brief about that. Meeting start with the prayer. May I request Dr. Sendil Kumar for the physician prayer and IMA prayer.
Thank you, sir. Physician's prayer. Dear Lord, thou great physician, I kneel before thee. Since every good and perfect gift must come from thee, I pray, give skill to my hands, clear vision to my mind, kindness and sympathy to my heart. Give me singleness of purpose, strength to lift at least a part of the burden of my suffering fellow men, and a true realization of the rare privilege that is mine. Take from my heart all the joy and worldliness, that with the simple faith of a child I rely on thee. I am a prayer. May everybody be happy. May everybody be healthy. May everybody be free from pain. May everybody be free from sorrow. May we be the healing cure beyond every greed and lure. Thank you, sir.
Thank you very much. May I welcome our chairman, IMA-AMS, Dr. Rajesh Babu sir. Dr. Rajesh Babu sir is a senior consultant, neurosurgeon, and head of the department in Ganga Hospital, Coimbatore. Sir is the former president of IMA Coimbatore, and Rajesh Babu sir is the chairman of Organ Donation Committee, IMA TNSB. May I request Rajesh Babu sir to give the welcome address. Over to Rajesh Babu sir.
Good afternoon, everybody. First of all, I welcome our state president, Dr. K.M. Abulasan sir, for giving permission to conduct this program on Indian Medical Association, Academy of Medical Specialities, AMS, and joining the program. I welcome Dr. Kartik Prabhu sir, our honorary secretary, Dr. R. Gunasegaran sir, the National Vice President, IMA Headquarters, Dr. Sendamil Pari sir, immediate past president, and Dr. P. Sengutuvan sir, State President-elect 2024, Dr. V. Sridhar sir, State President-elect 2025. And also, I invite the national leaders, the Namita Gupta madam, the chairman of the IMA-AMS headquarters, and the secretary, Srirang Abgari sir. Today, we are having the consecutive meeting of the 6th meeting of the IMA-AMS webinar. And as our president was telling, we should conduct a meeting on the International Drug Trafficking Free Day. So we have clubbed that along with the World Blood Donor Day. Both days are very, very important days. I welcome the speakers of today's meeting, Dr. M.Sri Devi, and the moderator, Dr. Indumati, and also the speaker for the second topic, Dr. Ramya, Sampath, and Dr. A.P. Maithili as the moderator. See, our AMS is growing up very well. At present, we are having around 1,390 members in IMA-AMS. My only sincere request is those who are having the specialities degrees after the M.B.B.S, the diploma or degree people, please join in the IMA-AMS and use the services of the IMA-AMS Academy of Medical Specialities. And also, I request the people who are interested to conduct the courses to become the instructors for conducting the courses. And this membership fee for this IMA-AMS is only 1,180 rupees only. So it is a very small amount. From each and every branch, minimum 10 members join, we will have a huge number. That is my intention, and we are going to conduct inaugurate the sessions in different various branches. And this month we are going to have on 22nd the State East Zone IMA-AMS conference at Trichy from 4 p.m. onwards. I invite all of you to please attend the program. And also we are going to have in August the National South Zone IMA AMS National Conference for the at Chennai. I invite you all for the program. And regarding the courses, we are planning to conduct different courses. One course already we have launched, which is the laparoscopic IMA course. We are waiting for the participants to register, and once they register, we will be starting the course as early as possible in this month itself. And we are planning to conduct the different courses on infertility and also in the bariatric surgery and also in the pulmonology also we are thinking in terms of conducting the courses. I invite all the people, those who would like to join the courses, please register and join the courses. I welcome you all, one and all, for the program. Thank you.
Thank you, Chairman, sir. Now I welcome our IMA TNSB State President, Dr. K.M. Abul Hassan, sir, for the presidential address. Over to Abul, sir.
Thank you, Dr. Jayaraman. And my dear friends, good afternoon, all of you. I am very happy to participate in this IMA AMS webinar on Blood Donor Day and also International Drug Free Day. I thank all the people, all the office bearers who are participating today, including Dr. Gunasekaran, National Vice President, and Dr. Namita and Dr. Akbari, Chairman and Secretary, IMA AMS Headquarters, Dr. Singutwan, President-elect, Dr. Caesar, President-elect, and Dr. Karthik Prabhu, Secretary, and also the speakers, Dr. Devi and Ramya Sampath, moderators, Dr. Indumadi and Dr. Maitri. My dear friends, I am very happy that AMS is also organizing wonderful courses for the benefit of our members. With regards to our Blood Donor Day and the International Drug Free Day, IMA is always in the forefront as far as blood donation is concerned. We are having blood banks in many of the branches, and the blood donation is routinely done in many organized blood donation camps organized by many of our branches. As far as this International Drug Free Day is concerned, we have Anti-Drug Abuse Day, which falls on 26th of this month, and we are planning 2 kinds of activities, education and also some physical activity like the rallies and human chain, something like that, to prevent particularly the youth falling addict to drug abuse. So I wish this particular webinar giving lots of messages in this direction. I thank IMA once again for this wonderful opportunity, and also
Jayaraman, Secretary of the IMA AMS TNSB. This is our team. Dr. V. Rajesh Babu sir is the chairman of the IMA AMS, and Dr. Adar Sendil Kumar is Joint Secretary of the IMA AMS Tamil Nadu chapter. So this is all our activities. So May month, 2nd May, we connected our World Asthma and World Hypertension Asthma Day. So I connected the Facebook Live program for the general public awareness for the commemoration of World Asthma Day. And for our members from IMA AMS released the video clipping about the Asthma Education Empowers update on asthma. So by me for the for our own members' benefit. On May 8th, 2024, to commemorate World Red Cross Day and Red Crescent Day, IMA AMS released a video clipping regarding the accident and emergency admissions in government and government-recognized hospitals. So this is one of the important video clipping for our IMA members and general public also. 19th May, Sunday, from IMA, Chennai AMS branch of Chennai Villivakkam Ayanavaram branch, connected the SEMI program. So in that, Rainbow Children's Hospital participated, and they talk about all the neonatology and the vaccinations, dialogue on HPV, human papillomavirus vaccinations, and poverty amongst the plenty, anemia in adolescents. About they have a lot of discussion in our branch IMA Chennai Villivakkam. And so we had an inauguration of Academy of Medical Specialty AMS course, that is fellowship in laparoscopy, inaugurated by our president with all the leaders. we did a CME on this occasion also, LAPIMA webinar from the IMA-AMS. These fellowship course was started from June onwards this month at the Coimbatore, that is a gateway clinic. So we had a wonderful CME webinar program to commemorate this IMA-AMS fellowship laparoscopy course on 22nd. This is the IMA laparoscopy course application form and other details about that. So I request all the consultants, our members, kindly enroll in this program. Similar to these other metro cities also, we are going to start the IMA-AMS course in various branches. So 22nd May, IMA-AMS Coimbatore branch conducted the World Lupus Day program. They have a CME approach to adult lupus by Dr. Sundaram sir, and approach to pediatric lupus by Dr. Maheshwaran Mani sir, and lab investigation in lupus by Dr. Nagendran sir. Followed by, we had a panel discussion on lupus, Dr. Venugopal sir, Dr. Rajamani sir, and Dr. Magesh sir, Jaykumar sir, and Sivakumar sir, participated as a panelist and moderated by the Nagaprabhu sir. So we had a wonderful meeting in Coimbatore IMA-AMS. And 26th May, IMA-AMS all Chennai branches conducted the World No Tobacco Day awareness walkathon at Tower Park, Anna Nagar. Our immediate past president, Dr. Sandabil Pari sir, and our North Zone Vice President, Dr. Kasi sir, and the chief guest, Dr. Mr. Ravichandran, Transport Joint Commissioner, participated in this walkathon and flagging of them, and our FSS Secretary, Dr. Kamalakaran sir, and other branch leaders, neighborhood branch leaders, IMA office bearers from Ambattur, Avadi, Peramur branch, and Pudumali Harur branch, and Nom branch, all the branch president secretaries members participated in this awareness walkathon for World No Tobacco Day. And in MGM Healthcare, in MGM Cancer Institute, myself and other panelists, Dr. Raja, oncologist and radiation oncologist, took part in that live session, Facebook live session on the World No Tobacco Day program. And to commemorate World No Tobacco Day, so from the IMA-AMS side, we released a video clipping about the World No Tobacco Day harms, hazards of tobacco smoking, etc. By me for our IMA members. And this is the program Dr. Rajesh Babu conducted in the Udavum Karangal Orphan Home inmates for medical examination and other advice given by our chairman Rajesh Babu sir in Coimbatore from the IMA Coimbatore AMS wing. So with that, this is our handout. We wherever we go, we give to all our members, which contains all the details about the IMA-AMS activities and the physician prayer, IMA prayer. All the basic details are there here. And this is our main motto behind our IMA-AMS. We have to increase the membership and membership. So there are fees, one-time life membership for 1,180 rupees only. I request all the members, those who are having the postgraduate qualification in the diploma degree, kindly enroll in that IMA-AMS as a life membership. So each and every branch has to start the IMA-AMS wing. I request all the president, secretaries, and members kindly start your IMA-AMS Academy of Medical Specialties wing in your branches. So these are different kind of courses we'll be starting from June. Already started one course. So other cities also we are planning to start all the 6 months to 1 year online, offline courses for our own IMA members. We conduct a master class and workshop periodically. Observership program for all our IMA members. Those who want to have the upskill of this upskill of the training program, we can have the training program in multi and super specialty hospitals, private hospitals. For that, we are giving the slot. You can enroll as a observership in CCU or neonatology or interventions. You go and visit the hospital and see the procedures. You can update your knowledges. These are all our own IMA members. IMA-AMS is doing. So may I request everyone take part in that East Zone Conference of IMA-AMS at Trichy on 22/6. That is a prayer before one day before our state council meeting at Trichy. And we are trying to conduct the National IMA-AMS South Zone Conference in Chennai on 18th August, Sunday. So the theme of this conference is recent trends in specialties. So we are doing the monthly webinar with the CME credit points from TNSB. With this, I stop my conclusion, reports and all. May I request our leaders of our national and state for the felicitation. May I request our National Vice President, Dr. R. Gunaseran sir, for the felicitation address. Gunaseran sir.
Sumita madam from New Delhi. and Dr. Srirang Akbari, Secretary of IMA-MS Headquarters, and Dr. Rajesh Babu, Chairman of the IMA-MS Tamil Nadu Chapter, Dr. Jayaraman, Secretary of IMA-MS Tamil Nadu Chapter, Dr. Adar Sendal, Joint Secretary of the AMS, and the President-elects, Dr. Sengutuvan, Dr. Sridhar, Secretary Karthik Prabhu, Gauri Shankar, the Finance Secretary, and all the office bearers and the faculty members who are going to talk today in the important topic. First of all, I congratulate the team of AMS Tamil Nadu for selecting the important topics today, the blood donation and also the drug menace, to clear the drug-free world, especially not only India. This day of blood donation day and also the drug-free international day is fittingly celebrated in the form of creating an awareness among the doctors how to implement this blood donation and the drug menace among the younger generation of especially doctors. Already our state IMA has taken up in a grand way to prevent the drug menace through the medical students wing. Our state president has taken up this issue, and in this scenario, we are having this type of topics for the use of benefit of the members. I congratulate and wish the meeting all the success and to have benefit out of this, the members who are participating today. Thank you.
Thank you, Vice President Gudaseran sir, for our valuable advice. We will follow, sir. May I request our IMA-AMS Headquarters Chairman, Dr. Nomita Sivgupta ma'am. Over to Dr. Nomita ma'am.
Yeah, good afternoon to all of you. Congratulations once again on the 6th CME for this year. And I can see that the attendance is also very good. And you have covered a very important topic. Apart from blood donation, and drug abuse is also a rising problem with all of us. And it is very important to bring awareness and the problems that arise. And of course, the importance of blood donation is known to all. And congratulations on planning the different programs for the Blood Donation Day. All the best for the program. I would again like to please request everyone to increase the memberships so that, and increase your programs for the training programs also, so that we have more programs in your state. Thank you and all the best.
Thank you, Chairman, Dr. Nomita Gupta ma'am, for your valuable advice. Definitely will increase the IMA-AMS membership, as well as we'll start all the courses in all the hospitals, ma'am. Thank you very much, ma'am. May I request IMA-AMS Honorary Secretary, Dr. Srirang Akbari sir. I think sir is traveling, I think, anyway. May I request IMA TNSB President-elect 2024, Dr. P. Sengutuvan sir. Over to Sengutuvan sir.
Good evening, everybody. I respected State President, Honorary Secretary, Finance Secretary, National Vice President, Dr. Gunasekaran, National Leaders, AMS Chairman, Dr. Rajesh Babu, Secretary, Dr. Jayaraman, Joint Secretary, Adar Sendal, Secretary-elect, Dr. Sridhar. Good evening to all. Today is the important day, that is World Blood Donors Day and International Drug Free Day. Both the topics are very much important, and the AMS Tamil Nadu chapter is creating awareness about the importance of them. They are also organizing various important courses. I appreciate the AMS team. Already they have started laparoscopy course. So the speakers of the day, Dr. Indumari as moderator, Speaker Dr. Devi in clinical transfusion practice. And for the drug-free future day, Dr. Moderator Maithili, Dr. as a moderator, Speaker Dr. Ramya Sampath. I wish AMS team in a very good future and to create all important topics to all the delegates. So all the delegates, please utilize this opportunity and join the courses, join the various courses they are going to operate. Thank you very much. Over to Jayaraman.
Thank you, President P.S. Goodwan, sir. Thank you for very well advice. May I request IMA TNSB President-elect 2025, Dr. B. Sridhar, sir.
Thank you, Dr. Jayaraman. The most respected President of IMA TNSB, Dr. Abul Hassan, National Vice President, Dr. Gunasegaran, sir, IMA AMS Headquarters Chairman, Dr. Namita, Madam, Secretary Srijan Gabkhari, sir, and our own office bearers, Dr. Karthik Prabhu, Gauri Shankar, IPP, Dr. Paris, sir, and my dear old brother, Dr. Sengutuvan, sir. I think today's topics are very relevant and periodic in the sense now we are facing an explosion of drug abuse and a lot of news is coming across about the seizure of this and that in the Gulf, here in Tamil Nadu, in Andhra. Economic menace. A whole generation of youngsters are getting trapped into this very dangerous habit. And it is our social responsibility, more than academic, it is our social responsibility to go to the rescue of the innocent youngsters who get trapped into this. And I think IMA, AMS is very much dedicated to doing that, just that. And Dr. Jayaraman, Secretary, is already known for conducting such walkathons and creating awareness among the public. And Dr. Rajesh Babu working overtime to bring about such interesting topics into the fold of AMS. And I'm very sure the delegates have a very nice vista of information today for them waiting. I wish them all great success, and I'm very sure at the end of the day, our delegates will feel their time spent well. Thank you, and over to you, Jairam.
Thank you very much, sir, for your wonderful advice and the presentation. Thank you, sir. We'll follow all your advice, sir. Thank you very much. So we'll move on to the CME part. Shall we move on to the CME part? Rajesh Babu, sir. Sendil, sir.
Okay, sir.
Yeah,
Yes,
please,
sir. Okay, we can continue, sir.
Yes, sir. Yes, sir. So may I request Joint Secretary Dr. Sendil Kumar, sir, please take over and start the session CME. Introduce the topic and the moderator. Over to Dr. Sendil, sir. I'll stop.
A very good evening. We are going to start the first session of our CME, Clinical Transfusion Practice. I'm going to introduce Dr. Indumadi. She's a consultant in the Department of Transfusion Medicine and Govt Hospital, Chennai. She studied M.B.B.S from Thuthukudi Government Medical College and M.D. from M.D. Transfusion Medicine at Sri Ramachandra Medical College and Hospital. She was the best outgoing student award in transfusion medicine for the year 2023. She worked as a tutor in the Department of Pathology in the Vinayaka Mission Medical College and Hospital from 2017 to 2019. She presented a paper on blood transfusion in autoimmune hemolytic anemia. Is it safe? And got the best paper award. She presented a poster on donor adverse effects, adverse events among whole blood donors, a study from tertiary care hospital in national conferences. We welcome Dr. Indumadi Madam for this wonderful CME. Over to Dr. Indumadi.
On behalf of this World Blood Donor Day on June 14th, I owe my thanks to Indian Medical Association for organizing this webinar on a topic of clinical transfusion practices. And also I want to thank Dr. Jayaraman sir for giving me this opportunity to moderate this session. So every year from 2005, the World Blood Donor Day was celebrated on June 14th. So after Karl Landsteiner's birthday, who is a great scientist who contributed much to immunology and transfusion medicine by identifying A, B antigens. So without him, the transfusion will not be much become easier and the evolution will not be this much faster. So on this, after 20 years of celebrating Blood Donor Day, this year, the WHO released the theme as 20 years of celebrating giving. That is, thank you, blood donors. So I also want to thank all my blood donors who not only donate blood, but are willing to take off from their work, and they are also willing to travel much from the distance to donate blood and to save a life. So please treat donors with respect and don't take a donor for granted. So when a blood donor arrives in blood center, he cannot easily give blood. He has to pass all the stringent donor selection criteria, which became very much stringent, and nowadays it is very not easy to make a donor to donate. Even a donor, if it is he didn't get a proper sleep for 6 hours, he cannot donate. So after a donor passes all the criteria and all the medical examination, he can donate blood. So after we tested for transfusion transmissible infections, we are converting this one whole blood into 3 components by centrifugation. We are preparing red blood cells, platelets, and plasma, and we are saving 3 lives. And we also preparing cryoprecipitate, and from surplus plasma-derived medicinal products are also manufactured. So this all happens only when a blood donor donates. And he should be free from all infections and transfusion transmissible infections. So what is the best transfusion? No transfusion is always the best transfusion, because even though we are testing for all the infections, even there is a window period. Even we are following 4th generation CLIA and NAT, we are following in little hospitals in Chennai. But there is a window period even in nucleic acid testing for transfusion transmissible infections. So following a restrictive blood transfusion strategy is always recommended. So coming to clinical transfusion practice, this topic proper. So maintaining a line between this overusage and optimal usage of blood products is always difficult, because it is not dealt by little professionals. It is treated by multidisciplinary health professionals over multiple specialities for wide variety of patients with different diagnoses. We didn't know how much patients respond to blood transfusion. And also, we recommend to go for oral or parenteral therapy for nutritional anemia to prevent transfusion before any elective surgery. But the problem here is the patient adhering to this therapies orally or parenterally is much limited, and the clinical practitioners had to go for transfusion before any strategy. Since recruiting the blood donors is becoming much difficult these days, and for negative groups, we are recruiting a donor has become much more difficult. When people from blood center become sleepless certain days for recruiting like AB negative or O negative donors for major PPH or CABG. So following a restrictive transfusion strategy and giving counseling to patients regarding oral and parenteral therapies is recommended. And I am requesting all the practitioners to follow this, to limit the transfusion and to follow this restrictive strategies. So the topic proper is going to be much more explained by our speaker, Dr. M.Sri Devi ma'am, who's a D.G.O, M.D. IHBT. Ma'am joined M.B.B.S in 1991 batch in Sri Ramachandra Medical College and Stanley Medical College. And she joined a D.G.O in 1997 batch from RSRM, Stanley Medical College. And she did her MD 2013 in IHBT from the renowned Tamil Nadu Dr. M.G.R Medical University, where first the Department of Transfusion and the course MD IHBT was started. And she joined Tamil Nadu Government Medical Service in 2001, and she's nearing 23 years of service. And she joined her rural services in Ahapatnam and Cheyyar, Vellore districts for more than 3 years. And ma'am also joined the teaching institutions in Government Vellore Medical College and Thuthukudi Medical College for more than 6 years. And now presently in Transfusion Medicine Department as Senior Assistant Professor, Government Stanley Medical College. And ma'am taught students from M.B.B.S, PGs and other allied health sciences. She also given training about obstetric management to ANMs and also to blood center staffs. And she acted as a resource person in CMEs and published papers in national journals and put posters in various national conferences.
Good evening, everybody. Good evening, seniors and my dear friends. First of all, I thank IMA for this opportunity to join this meeting and to present my this topic on clinical transfusion practice. First of all, my slide starts with thank you slide. Usually this will be the last slide, but I have started this with a thank you slide. Like I want to say a couplet from Tirukkural. Tinai tunai nandi seyinum, pani tunaiyaga kolvar, payan therivar. To the discerning, even a millet of aid is a big ass as a palm tree. So this is time for to thank all our donors, which now has become the theme of this year's World Blood Donors Day.
Next slide.
20 years of
Next
20
slide,
years of
Ravi.
celebrating giving. Thank you, blood donors. So today's topic on clinical transfusion practice is on, it is going to deal on the evolution of clinical transfusion practice, hemotherapy decisions, special considerations, and all about the quality management system available in the clinical transfusion practice. So to give an introduction to what transfusion medicine or what blood bank is, we all know the most common transfusion procedure is blood transfusion. It is an invasive procedure and it is a fluid or a liquid transplantation procedure. So here it is a, and though in recent times it is a safe procedure, but still we face so many challenges in blood transfusion practice. One of the main challenges, the human resource, and blood is made safer and safer in modern times, but we are not without the risk of non-infectious transfusion complications. Still, we have many regulations and quality systems, audits, hemovigilance practice in that. So, in that way, this blood bank has traveled a vast milestones, and it has traveled many milestones throughout these many centuries and have attained the present quality and safe blood transfusion service state. So how does the evolution of transfusion practice came? So it started all with animal transfusion, animal to human transfusion, human to animal transfusion, and transfusing the coagulated, defibrinated, anticoagulated blood. And even before the substitutes of blood discovered recently, even before we had wine, milk, saline, all as blood substitutes. And after invention of the blood groups, blood bank establishment, and the contribution of world wars, all this has paved the way of the evolution of this current blood transfusion practice. Universality of the O blood group used as universal donor, plasma drive, and all has given way to do rational use of transfusion practice. So the next step was, it was 10-30 rule. So what that is? A 10-gram hemoglobin percent. If anything less, it is to be transfusion should be planned. So even very earlier, in earlier days itself, the unnecessary transfusions has been limited. And one doctor, Dr. Adolf Lorenz, he's an orthopedician basically, and he was doing a bloodless surgery because of his allergic symptoms to carbolic acid in the theaters. And also Dr. Aaron, he was from John Hopkins Hospital. He was managing the Jehovah's Witness patient. I'll say about them later. He was doing bloodless surgery for them. And very early in 1957, Dr. Denton Cooley, he was called father of modern bloodless surgery. Though he was very famous for his first total artificial heart implantation, he was very happy to say that he has done many bloodless surgery in his times.
Slide.
And after the outbreak of HIV epidemic, the question of getting safe blood from the quality donors was very questionable. So people were really worried about the safety of the blood what we get from the donors. So the banning on the professional donors and quality screening of the donors by getting a very quality history intake, screening the donors by the donor health questionnaire. That is a very important part of getting a safe and quality blood from the transfusion service. And late 1990s and the recent years, we have taken many efforts to rationalize the blood usage by the clinicians. And one such thing is the latest one is the patient blood management system that is called PBM. It is a standard of care. It was given by James Isbister from Australia. He only coined the term patient blood management. So after using, I mean, at the latest in the quality management system is the patient blood management system. See, nowadays, apps are available for it, and we have transfusion audits, hemovigilance, which enhances the quality transfusion practice. So let me highlight some few words about the importance of the blood center. So every blood center in the world or in India is a licensed blood center. So we need to have a license. It is regulated here by the Drugs and Cosmetic Act 1940. So for all the blood centers, the main pillar is the altruistic, voluntary, non-remunerated blood donors, VNRBDs. And these people only will help us in making the quality transfusion service. That is the mantra. The quality blood donors is the mantra for our patients' blood safety program. And we are also governed by many regulatory agencies like DGHS, NACO, NBTC, SBTC, TANSEX, everyone, all over the country. Slide. So, to say about the structure of a blood center, we have a collection arm. That's what Dr. Indumati ma'am was elaborating. And we have a recipient arm. The topic is all about today about the recipient arm. So, recipient arm is after collecting the blood from the donors, storage, testing, and all other processing matters. This blood is issued when there is a request from the clinician side. So, whenever how does a clinician decide? When a clinician decides based on whether this patient is really a right patient to get the product, whether the right product has been given to the patient, and it is the right time to transfuse, right volume is transfused. For example, if a patient is an anemic patient who needs a transfusion, whole blood is not an indication. So it is not a right product. And before going to failure or to prevent failure, we have to transfuse. So that should be the right time. And transfusing a patient with 3 or 4 units of blood on the same day to correct the anemia is not a right volume. And a right rate is very rapid transfusion in an chronic anemic patient is not a right rate. So a clinician decides about the prescription of to whom to give. Then whether it is an elective or emergency transfusion is a important matter for the blood bank perspectives. So before after deciding, he gives the prescription in his progress card for the patient, in the progress notes of the patient. After raising the prescription, the blood request is raised. So after all this is over, the patient is positive patient identification. That is, the identity of the patient is future transfused patient is identified. Then the sample is taken. The sample taking process is very, very important. So the samples are to be collected from the 2 samples, that is EDTA sample and a plain sample. It should be 2 samples taken by the 2 different phlebotomists, and at the same time, it should be a non-labeled tube, a tube which is an empty one, which is not labeled. In that, the blood sample should be taken. Then the bedside labeling is to be done. When the labeling of the test tube is done away from the bedside of the patient, labeling errors are more prone to occur, which is going to give you mismatched transmission errors and acute hemolytic transfusion reaction and fatality of the patient due to transfusion. So the important step is positive patient identification, bedside labeling in a test tube, then with the request and with the test tube, this thing is brought to the blood center. There, the identity of the sample, the request, the genuinity of the prescription is all checked and the sample is received. After the reception, this grouping and other grouping is done by the 2 different lab technicians in the blood center. So after doing all this, and prior to that, the clinician will really weigh the risk and benefit ratio of the transfusion. Then only he decides about the prescription. So after doing all this request, sample collection, so you can, this slide shows how a sample should not be taken. Next, how the sample should not be taken in a syringe or a small bottle, or the hemolytic samples are not allowed. Next slide. Next slide. Next, yeah, this slide shows a sterile connecting device. The importance of this device, I'll tell you later. And this is an apheresis way of collection of blood components. Next slide. So when you do a labeling for a manual labeling, increases the labeling error in 1 in 3,000 samples. Electronic system like RFID, radio frequency information device, all these are used to avoid the labeling error, where the transfusion error is, labeling error is minimized to 1 in 15,000 transfusions. And next is the pre-transfusion testing procedure after grouping. So that may be a type and hold and type and screen, or type the screen with cross match. So based on the priority of the transfusion, like is it an emergency priority or an urgent priority, or it is a elective priority? Based on that, the processing of the samples for further issue of the blood will be done. Next. Next, please. So for any transfusion processing, any blood issue, the sample submission well in advance is very, very important. Exception is the emergency situations. So next slide shows the priority status of blood transfusion request. Next slide. So this slide shows we should really know the switching of the blood in times of emergency. Many clinicians really want to transfuse the same blood. If it is O positive, the patient, that should be given. If it is A negative, only that blood I will accept. This concept should be really discouraged, because scientifically it has been proved that in types of emergency, the alternatives are switching across the blood group should be also practiced. I can remember one incident that an obstetric patient who came as an emergency in an obstetric unit in a medical college, she was really a B negative group, but because the B negative group was not available in the blood bank, the blood bank medical officer gave them the O negative. But the obstetrician was really not aware to use it. But patient was referred to the higher center. On the way, the patient died. But if it has been a O negative transfused and sent, maybe there is a possibility to save a patient. So we should always know what blood can be used in times of emergency. This chart, we should place it in our emergency department, and we have placed it in our blood center also to guide our staff, to our staffs and other people, so that it will help in times of emergency. Next slide, please. So next, what are the components that are available from the blood bank? It may be a whole blood, packed red cell component, granulocyte, plasma, platelet, cryo, all that. But granulocyte, the component is very rarely prepared in any of the blood banks in our India, and whole blood transfusion practice also discouraged. Component therapy, blood component therapy is all we encourage in modern healthcare. Next, and on how to give these components. PRBC, whole blood, and granulocyte should be given the same group, that is identical group of the patient. And in times of emergency, O negative or O positive may be encouraged. If at all the compatible or the identical blood is not available. And platelet can be given, any group across the group can be given. Platelets should be given the same platelets. Not platelets, the plasma should be given the same plasma. And if it is not available, the emergency plasma AB can be given. Because of its less inventory, we encourage to give A plasma. And cryo can be, any group of cryo can be given. So this is the blood group compatibility and the transfusion practice. We should all should be aware of this kind of practice. Next, what is the storage temperature? So most of the components that are available in the blood bank have specific storage requirements, like whole blood PRBCs have 1 to 6 degrees as the storage temperature. Platelets have room temperature. Plasma and cryo has the frozen temperature. Their lifespan is also different. So what I want to stress in this slide is, many a times our transfusion people, the clinicians, the person who get blood from the blood center, they collect the blood. If they don't have enough time to transfuse, they place these components in their domestic refrigerator in the ward. This should not be, this should be avoided, because each component have its own storage temperature that will be present only in the blood bank. So if you have any delay in transfusion, kindly hand over those components in the blood bank, so they will store in the respective temperature. And if you are in need, they will hand over to you. So this point is very, very important. If not so, the cold chain is lost, and there will be hemolytic reaction for the patient, which will lead into non-immune and that is fatality. Next, what are the special products available? It is a leukoreduced products or the platelets and red cells, irradiated products, saline washed products, and SDP from apheresis, pathogen reduced products. Next is, how will you reserve? Reservation can be done the one day before or especially for elective surgeries. Next. So blood in all blood transfusion procedure after FC, now we have given the sample, the product has been distributed, a person has collected the product, they are going to the patient side to transfuse. So before transfuse, we should do certain procedure called bedside check. In the bedside check, we have to identify the product, the patient, and also the prescription. So because this is the last chance to identify the identity or the correctness of the product, patient, and the prescription, so that to avoid the near miss event. So this last chance is very, very, very important. So we have many strategies or many methodologies to identify the patient, the product. So we give a issue card from the blood bank. So that card should be verified with the case sheet and also the patient identity and also the patient unique number, which is tied on the wrist. And also, what are the don'ts that have to be done during or prior to transfusion? Vitals should be checked. It is a must. And no pre-medication is encouraged. No routine warming is also encouraged. And also, unmonitored or unauthorized blood transfusion is not encouraged. So this is very, very important. If you don't have any people to monitor an elective transfusion, it is better to postpone the elective transfusion the next day or some other time. Unmonitored transfusions always land up with trouble. Next slide, please. We have to follow the golden hour rule. That is first half an hour or first 15 minutes with the onset of the transfusion. So in the initial minutes, 1 to 2 ml per minute of blood is being transfused, so that any reactions, if at all it happens, we can get hold at an earlier time and the injury to the kidney is very much minimized. So this is a very important period. If any reaction is there, what we should do is, it should be a reflex action to stop the transfusion. Suspecting reaction, stop the transfusion. That will be the ideal method we have to follow. This step should be, should be taught to every interns or every practicing transfusionist, because I've come across so many places like this. Like when I was doing my work in my other previous stations as an obstetrician, my house surgeon, who is very new to that, new when she entered her internship, what happened? They doesn't know to stop it. So on finding out it is a mismatch, they are not aware of it. But suddenly some other people were helping. So it is an important duty to teach all our budding doctors and other transfusionists to stop transfusion when you suspect any reaction like fever, allergy, or rigors, pain, all that. Then using the transfusion, what is the access, intravenous access? 25G to 14G, that gauge is being selected. For any emergency transfusion, 14 gauge needle is selected. Next. The rates, usually we practice 1 to 2 ml in the initial golden period, followed by the 4 ml per minute. And all the elective transfusions of PRBC should be completed by 4 minutes. And platelets, plasma should be started immediately. And it should be ended by half an hour to 1 hour. And the thing is, when you receive blood from the blood bank, it should be started within half an hour of reception. There should not be any delay in starting the transfusion. If so, there will be bacterial contamination and patient will land up in bacterial sepsis and septic shock. And there will be break in the cold chain because of break in the cold chain. Next slide, please. Next slide. So documentation, what all we did from the sample collection till the transfusion, monitoring, everything should be documented in the case sheet, because this is the only documentation which is going to which is going to save us from any litigation. So transfusion order, consent, getting consent is so important. Without the consent of the patient, transfusion should not be practiced. Component name, other identification, adverse reaction, if at all present, should be also documented in the case sheet. So what is it is, if it is not documented, it is not done. So make sure everything is documented. Next slide, please. Next slide. So now about the hemotherapy decision. So whether to transfuse, how to transfuse and when to transfuse. So there are many trials that has been conducted recently and time earlier before, like trick trials, focus trials, all has shown that there is no benefit of liberal transfusion. Liberal transfusion is anything more than 10 mg/% to transfuse. The idea of transfusing. There is no benefit of transfusion in liberal way. Whereas AIBB and other agencies and organizations have advocated, they have given the guidelines to have a restrictive transfusion practice. They are guidelines, they are not standards. So it is not a substitute for a clinical judgment. So it is better to standardize our practice based on the individual patient condition. So, and also anything like storage, like a blood component which is stored for a longer period, and like if that is 42 days storage, I am issuing a blood of 30 days old. So storage age of the product and the outcome, benefit outcome does not have any correlation. So always our clinicians are very fond of fresh blood. Fresh blood is not the one which is collected on the day 0. Fresh blood means it is 5 days or 7 days old blood. So fresh blood, it is usually advocated for the cardiac patient or the newborn or the pediatric transfusion practice. Even then, the age of the blood and its beneficial outcome of the blood transfusion is not having any correlation. So it is better always not be strict on asking for the fresh blood. And now let me talk few words about what is our transfusion practice in anemia. We all know anemia is a global health issue. So we always treat anemia now and then, any medical patient, surgical patient, obstetric patient, all types of patients, pre-surgical patients. So any chronic anemia, RBC transfusion should not be a default option. Next slide, please. RBC transfusion should not be a default option. Or restrictive transfusion practice is done. So anything less than 7 g/% hemoglobin transfusion is recommended. And for cardiac patients, anything less than 8 g/% transfusion is recommended. Next slide, please. So these are the societies which are encouraging and which has given guidelines to practice restrictive transfusion practice. Next slide, please. And these are the trials that is done on the critical care patients and coronary patients, sepsis patients, mechanical ventilated patients. These studies have shown liberal transfusion practice as not having an added benefit. It is having the same benefit as that of the restrictive transfusion practice. Next slide, please. So we should know what is trigger and threshold. Trigger is like anything about 10 grams or less than 10 grams, you automatically give a transfusion. But threshold is above this threshold, you can avoid transfusion. Transfusion can be safely avoided. So in those patients, alternatives to blood transfusion should be considered. Next please. So managing a chronic anemia, a default blood transfusion practice is not advocated. But instead, we should find out the cause, severity, and other comorbidities, and use other replacements like iron, erythropoietic stimulating agents, antifibrinolytics, topical hemostatics, less phlebotomies. See, many studies have shown that getting samples for doing laboratory investigations is also one of the cause for anemia in newborn children and pediatrics, and also in intensive care unit patients. So limiting our blood drawing sample volume for testing procedures is done by using micro containers and other methods. And also one important thing in the latest recent update is conduct preoperative anemia clinics. Correct the anemia preoperatively so that blood transfusion need is avoided or minimized. This is a very important strategy which has to be kept in mind in recent days. Next slide, please. Now I'll give some two points in each special conditions. So sickle cell condition and thalassemia, we have to reduce the anemia and also reduce the extramedullary hematopoiesis in thalassemia and other sickle cell crisis and other complications. So it is important they have a chronic transfusion from childhood, these two types of patients. And also other strategies are present to avoid hyperhemolysis like steroids, intravenous immunoglobulins, rituximab. Main thing what I want to say is these patients are more prone for alloimmunization because of chronic transfusion. So we should really reduce alloimmunization. How to reduce it? We should really give a phenotyped matched blood or extended phenotyped matched blood. More than that, in earlier days, like in childhood transfusion itself, we should really designate a donor, like a doctor appoints one donor for that particular patient. That patient will be, one or two patients will be donating for that particular patient. So designated donation is really encouraged to avoid alloimmunization to these patients. Next slide. Next condition is autoimmune hemolytic anemia. Here, the main, there are many reasons for autoantibodies like IgG, IgM, but the main management is immunosuppression with steroids. But RBC transfusion is also advocated to as a life-saving agent for treating anemia. But most of the time, blood bank is facing a problem to find a cross-matched compatible blood because of these autoantibodies. But for that sake, we should not leave the patient not transfused, because this non-transfusion will endanger the life of the patient. So we should at least find a best match, that is called least incompatible units for the patient, or extended type phenotyped blood. We should not leave the patient without transfusion for that sake. This is the very important carry-on message I would like to say for autoimmune hemolytic anemia. Next slide, please. So there are recent treatment in oncology patients and other conditions. They are taking anti-CD8 monoclonal antibodies. In these patients also, we find difficult to find a compatible blood. So here also we encourage phenotyped or genotyped matched blood. Next slide, please. And all the surgeons, this is called maximum surgical blood order schedule. Here what we do is, based on the local practice of the surgeons utilization, we and also cross-match transfusion ratio, we devise this table. And for certain diagnosis and surgery, this is the recommended units. So we have to practice it. Anything ordered more than that is an excessive ordering. So auditing should be done, and the reduced transfusion practice should be encouraged. Next slide. Now, a few words about autologous blood transfusion. In earlier days, when there is an outbreak of epidemic of the infections, autologous blood transfusion was practiced. But recent days, this is not encouraged because of costly procedure, and many clerical errors can occur. But still, because of the shrinkage of donor pool, some patients are really encouraged for autologous blood transfusion, especially in rare blood group people and Jehovah Witness. Some Jehovah Witness also like to have autologous blood transfusion, especially in cardiac surgery, hip and knee placement surgery, when the hemoglobin is 11 gram per cent. This is very, very important. And here, these units may or may not be screened for HIV and all that. So this should not be used for any other patients. And the transferring this unit for some other hospital, if unused, is also not encouraged. So this is very important. So there are many varieties of autologous blood transfusion. It may be pre-operative. That is, pre-operatively itself 3 days before you deposit the blood, and it is used during operation. Or in the perioperative setting called as acute non-volemic hemodilution in the anesthesia setup. And also intraoperative cell salvage, post-operative cell salvage. All will reduce the allogenic blood transfusion requirement. One thing we have to keep in mind is the cell salvage will give you red cells only. So it is not giving platelet or plasma. It has to be supported with platelet and plasma externally when we use cell salvage product. So massive transfusion, which is here we have to follow the 1:1:2 ratio, and this has been goal directed, and it is a balanced transfusion should be followed. So next slide, please. Next slide. Usage of TEG in the massive transfusion should be encouraged. And intrauterine transfusion and neonatal pediatric transfusion, especially in intrauterine and neonatal, which should be the maternal compatible blood should be used, and it should be leukoreduced and irradiated sickle cell hemoglobin trait negative, CMV negative blood should be used. And there are aliquots are also available. In obstetrics, they follow Green Top guidelines and FOXY guidelines for their blood transfusion practice. It is entirely different from the other general transfusion practice. And a word about Jehovah Witness. Here, people don't accept blood. So there are so many, many hospitals have been opened to manage these bloodless therapies for such patients. And platelet transfusion is prophylactic and therapeutic are available. Prophylactic and therapeutic transfusion is given without bleeding, less than 10,000 per microliter if the patient count is. And there is contraindications for post-transfusion perpebra and ITP, heparin-induced transfusion, and TTP. And plasma is used for so many conditions like dysfibrinogenemia, DIC, warfarin reversal, and other factor deficiency concentrates. And their plasma derivatives are also available. We should really aware that blood still kills in modern days because of so many transfusion reactions like TRALI and TACO. So we should be aware of it, and the reduced or restricted transfusion practice should be encouraged to avoid all this transfusion reactions. Next is a word about national blood policy. Objective 5 of national blood policy says we have to encourage the appropriate clinical transfusion practice, for which now patient blood management is being encouraged. There we have 3 pillars. 1, to correct anemia and optimize the blood tolerance and also restricted transfusion practice. So single unit transfusion is also once again coming into practice. Low titer whole blood volume, whole blood is also used. Fresh blood, whole blood is also practiced. And we should institute hospital transfusion committee to remove the misunderstanding between the clinicians and the blood bank and to give the quality transfusion practice. And there is a program called Hemogenesis Program of India, which improves the donor recipient quality and also our transfusion practice. So to conclude, blood still kills. So, and blood has only human resource. It has only the human resource. There is no replacement for it. So we always should be aware of rational use. And blood should wait for the patient and patient should not wait for the blood. So my references are from AAB, and any references, NACO website can be accessed, and blood safety portal can be accessed to get all this.
Please go to the last slide.
Last slide, please. So all this material is present in that. Thank you so much for this opportunity. And especially, and this is a vast topic, I've tried to put it in a shorter time. Thank you so much.
Go to moderator Indupati ma'am. You can conclude, ma'am.
Thank you.
Indupati ma'am, any questions in the chat box? You can take some questions.
Thank you, ma'am. Thank you for the detailed presentation of the clinical transfusion practice. I'd like to add only 2 more points, ma'am. That is, most of the transfusion reactions are happening only in night, because for anemia, the transfusing in night, and most of the errors happening in night because of manually there will be less people only to monitor, and so the labeling errors also occur in night.
For that only electrotransfusions we always advise to do it in the daytime. So only emergency transfusions should be done and after the evening, or where very less staffs are present. So it's better to always plan an electrotransfusion when everyone is present and all the staffs or any people for emergency is present or present.
And another doubt from everywhere is they will have a transfusion reaction. What they will do is they'll just disconnect the line. They will start transfusing some medications in the same line of transfusion. That is, they will give some paracetamol or whatever medication. They will stop the transfusion. They will hang out the line in the stand and they will start giving the medication in the same line. So, and they will ask if any reactions occur, they also will be stopping the transfusion. They will disconnect the line and they will call us. Ma'am, there is a reaction. We gave paracetamol, whether to continue this or not. This will be everywhere. This question will be there, ma'am.
Yes, so, of course.
That cannot be done because once transfusion reaction occurs, we cannot start the same bag transfusion. We should disconnect it and we should send the sample along with the bag to the blood center within half an hour of the reaction, so that only transfusion reaction workup can be done correctly. This has to be followed everywhere. And next is whole blood, asking for whole blood. Everywhere they will ask for this is whole blood. There is bleeding, profuse bleeding. We need whole blood. But the problem here is the platelet should be stored in 20 to 24 degrees Celsius. Here in the whole blood, they will be stored only in 2 to 6 degrees. And the platelet will undergo cross-linking and activation and it will not meet its own work. So going for component therapy, 100% component therapy is always advised. And there are questions in the chat box.
Madam, nare questions irukku, madam. Is stem cell therapy is the alternative to blood transfusion?
No.
Sir, stem cell therapy is not always alternate. Sir, stem cell therapy is completely different, sir. Stem cells will be taken from the patient, only given for patient with leukemia or any blood discresis disorders, lymphomas. This is not alternative to blood, sir. Ma'am, your thoughts on that, ma'am?
Yes. What she says, what Dr. Indu ma'am is saying is correct. So nowadays pluripotent stem cells are used. I mean, they are used to to design our blood products. The research is on the way. So for that only it is used, but stem cell therapy is entirely different. It is used for as a transplant procedure for malignancy, all that. It is not a substitute for blood transfusion. Definitely not.
Okay,
any
madam.
Possibility of artificial blood in future? That was another question, ma'am.
So it is so many years, like so many years, the research has been going on, but still we have not found one such thing yet. But there is something called hemoglobin based oxygen carriers, something. But all these have many complications which prevent us from using it in a routine use. I mean, in day-to-day transfusion practice. And another thing is that is called universal O cells, echo cells, like say enzyme converted O cells. All this research, even though it is well established, but their inherent complications in their day-to-day use prevent us from usage. Still, we have to go a long way to find one artificial blood substitute. But as of now, we have only the human resource as a for transfusion.
Any impact on blood transfusion or donation in patient with history of COVID?
Most history of impact of blood transfusion and history of
or
COVID.
For donation and transfusion, both, madam. Is the COVID patient should have any restriction?
No. See, if a donor is a COVID affected, we give them 14 days or 28 days deferral if he is positive or he is vaccinated. So this is a respiratory infection. It is not going to have any COVID infection transmission through his product. But as I already said, restrictive transfusion practice is so important in patient side. Even COVID has so many inflammatory mediators. All that it has its own problems. It has its own complications. So if it is necessary for them to transfuse, or else to avoid transfusion unnecessarily is more wise than giving giving transfusion for unnecessary conditions.
Thank you, madam. God bless you. Thank you.
For chronic anemic patient on workup found to be predominantly myeloid cells suggestive of myelodysplastic syndrome, what's next? If a patient
so this has to be so they have to go for the they have to go for the hematological workup and they have to proceed further. So this has nothing to do with the transfusion department. But these patients may need more special products or more because they might need, land up in pancytomenias also. So they might need many blood products, specialized products. That way we will help you. But the hematological workup is a must and we have to follow this patient.
Is he trying to inject pre-transfusion medications like Avil and dexamethasone before blood transfusion?
Nothing. I've told in my presentation, so no medications. If at all, it may be required. Diuretics can be added. No dexamethasone, no Avil, or like anti-allergens or analgesics or any other drugs. Even in the port, in the blood bag port. But one drug which can be tried maybe a diuretics, so that to avoid overload because of transfusion.
Can subclinical hypothyroid patients be considered as donors for blood transfusion?
Subclinical, we want to confirm they are not toxic. Their condition is not toxic and they are not hypertoxic. So if they are not on any other endocrine, hormonal treatment. If that is so, we will decide for donation, and the final decision is made by the medical officer who was handling that donor.
The madam said, right unit, right product, right patient, right time, right volume. This is much more needed now, and following a restrictive strategy for blood transfusion is recommended all over the world because recruiting donors and the risk of transfusion transmissible infection is still there. We are recommending all the transfusion medicine specialists, if you ask, they will recommend only restrictive strategy and they will recommend to go for component therapy. And switching between groups is always a difficult part in all the hospitals. So it is the duty of the transfusion medicine specialist to explain to all the practitioners about switching the units, because for giving O negative to AB negative or B negative itself is difficult nowadays. So explaining to the practitioners about this to prevent huge blood loss and to save a patient, we are always recommending to go for alternative blood group transfusion as per your transfusion medicine consultant's advice. And if any reaction occurs also, please inform to the blood center and don't start the transfusion with the same bag at the same time. Don't start. Even if it is a febrile reaction, we never know. That will cause a higher reaction only if you start again, even after giving any paracetamol or anything. So don't start a if there is any reaction. And if you have any doubt regarding transfusions or any donation, please ask the medical officer, get clear of it. They may close the door for donation or give a transfusion to a patient.
And one more question. Cutoff value for platelet infusion.
Sir,
Cutoff value for platelet infusion, madam.
Sir, ma'am, Sridevi ma'am, would you like to answer, ma'am?
Hello? Huh? Hello?
Sir, cutoff value depending upon the patient's stability, sir. If the patient is stable and if there is, for example, in acute febrile illness, if the patient is stable and if the count is 20,000, you can wait. But if there is any superficial bleeding, for any count, you have to transfuse platelets, sir, for any count. If there is any superficial bleeding or inner bleeding, you're suspecting, for any count, you have to transfuse. For stable patients, you can wait till even 10,000. But before 10,000, you have to go for transfusion. And there is always a myth between transfusing random donor platelets and single donor platelets. Most of the consultants nowadays in apheresis therapy, if this present in apheresis procedure is done in some hospitals, they always ask for single donor platelet even in emergency. To collect a single donor platelet, it will take at least 2 to 3 hours. The procedure itself will take 90 minutes. And the donor should be eligible. Before that, it will take at least 60 minutes for processing the questionnaire, the examination, the TTA infection screening. So we cannot get STP at an emergency. So please go for random donor platelet infusion, but it should be at the correct dosage. For example, for STP, if you are going to give for an adult 1 unit, in the patient, if you are going for RDP, for 10 kg weight, you have to give at least 1 unit. So for a 60 kg man, you have to go for at least 6 units to get the desired result. By just simply transfusing 2 units, you will not get the result, because with 1 RDP, with this 6 only, you will get at least 5,000 to 10,000 increase. With STP, there will be at least 30,000 increase, but it also depends upon the patient condition, patient diagnosis, and the response to platelet infusion. But going a stable patient, you can wait till 10 to 20,000, sir. Ma'am, your thoughts?
For a stable patient and without bleeding, we can wait till 10,000 platelets per microliter. And for other cases like neurology and other pediatric cases, we can wait up to, even without bleeding, the threshold will be 50,000 per microliter, and we have to consider for platelet transfusion.
Thank you very much, madam. So, very nice, wonderful session to commemorate World Blood Donor Day. I thank you, Dr. Indumati ma'am and Dr. Sridevi ma'am, for this wonderful update on this day. So, thank you very much.
Thank you, sir. Thank you so much.
Next session. That is another session is the International Day Against Drug Abuse and Illicit Trafficking. This is an important subject. May I request moderator of this, Dr. A.P. Maithili ma'am. Introduce today's speaker of this Anti-Drug Abuse Day, Dr. Ramya Sampath. Madam is a senior consultant psychiatrist in the MGM Healthcare and Poorna Mind Care Center in Chennai. Dr. Ramya Sampath, ma'am, you can start to share your screen and you can start the presentation, ma'am.
Thank you, sir. Yeah. So over to Ramya Sampath. Very good evening, one and all. And at the outset, I would like to thank IMA AMS wing, Jayaraman sir, and the senior members of IMA for giving me this wonderful opportunity to speak on drug abuse. I think very similar to transfusion medicine. This is, this topic warrants a workshop on its own. We all know how common drug abuse is and how do we deal with it on day in and day out. But however, my aim of this discussion, I'll try to make it as crisp and short as possible, maybe for the next 20 minutes. And let us try and look at how are we to understand what drugs do to our brains and what is that we can do to prevent drug abuse in our society. So thanks again for this wonderful opportunity. My slides are visible, sir?
Yes, ma'am. Visible, yes.
Okay, thank you, sir. So my outline of my presentation would be like, why would somebody use drugs in the first place? So is it for recreation? Is it for relieving stress? Is it for peer influence? So how do you understand stress? And more importantly, I would be focusing on developing brains or adolescents, because many a times the drug initiation and getting into dependence happens during the developing brain phase, that is during the late adolescence or early adulthood, that is around 16 to 17 years to 22 or 23 years of age. What are the common maladies or common issues that we face? Depression, anxiety, things like that. So what are the common substances that are abused and what is the impact of that? And how can we conceptualize a drug-free future? What is this year's theme and conclusion? So just a second on to just really understand where our mind is. So many times we do get somebody like bringing in an adolescent saying he's abusing cannabis, he's doing drugs and all that. So why don't you counsel and clear his mind off and send him back into the society? Generally, then we are just taken aback, like how do we have a vacuum cleaner for the mind which works just like that? So where is our mind? So mind is conceptualized as a biological functioning of our brain. So it's our own brain, the way we understand our environment, the way we understand our stress, the way we relate with somebody, the way we conceive pleasure, with the way we understand pain. So everything is happening at a neuronal level. So mind or the emotional level or the logical level is also related to the brain. So as doctors, we should understand that mind is placed in and out of brain. So a lot of times we hear this phase where we ask, Chumma, like just for combating stress, I take some amount of alcohol every day. I just smoke once in a while in my office to just counter my stress levels. So what is stress? What do you call as stress? So there is no litmus or no scans which can demonstrate how stressed you are. So it is only a perception. When somebody feels, when they are dealing with day-to-day life challenges, professional challenges, or personal challenges, we all have our day-to-day demands on one end, which we got to meet and which we are struggling to meet. And we all have our coping skills. Somebody may cope up by reading a book. Somebody may cope up by going to a temple. Somebody may cope up by venting out to a friend. So we have our own unique coping skills. So it's actually a balance. Stress is a very dynamic balance. So when the demands outweigh the coping abilities of somebody, that is when we call stress. I am feeling stressed because I feel I can't handle this situation. I'm not supported enough to handle this situation. So it's important to understand stress because stress is a very, very subjective thing. So when you get an adolescent saying, Madam, I am struggling with a relationship breakup, so I'm abusing drug. So a relationship breakup might seem very logical and okay for the listener, but for the person, it is a tremendous stressful experience. So the take-home message here is stress is very subjective and it's a perception. So sometimes there are two types of stress broadly. I'm not going to dwell deep into it. So eustress is the healthy stress or the green part, if you can see the graph, where you are able to improve on your productivity. For example, today I prepared for this presentation. So though I felt a little stressed about it, I ended up preparing and reading a lot. So somehow stress helps us to cope up with situations. Until then, it is good. But if the same stress is overshooting your threshold, something that becomes unbearable or something that is overshooting your coping ability, it becomes distress, fatigue, discouragement happens, burnout happens. That is when people use substances to cope up. So why are we so bothered about adolescence? As I already mentioned, adolescence is a very, very unique phase. So where they undergo a lot of physical, cognitive, social development, identity. How am I to my friend? How am I to my college teacher? How am I in my workplace? So a lot of identities keep evolving at that time. That is when they get into a lot of moral concepts also. What is moral? What is not moral? So what is that I can really ground myself upon? So this is one important slide I would just want you to listen. So a growing teen brain or an adolescent brain, we can broadly categorize into two levels. One is the early adolescence, that is the 10 to 18 year level. And the next is the maturation phase, 18 to 25 years of age. So we all have two components of our brain, if I have to put it in a very, very reductionistic or simple way. One is the limbic system or the lower half, the amygdala, the hippocampus and things like that. The limbic part of the brain, which is intensified during our puberty with hormones along with other hormonal surges. and it helps in rapid cognitive, emotional, social growth from childhood to adulthood. So the adolescents start feeling more emotional, aggressive, autonomous. We feel, as parents or as others who are observing an adolescent, we feel they are like more independent now. They don't listen to us. They have their own decision making. So why is it? Because the limbic system is maturing at a very, very rapid rate. They are super sensitive to criticisms. They are emotionally driven by what is happening around them. That is what is prompting them to engage in greater risk-taking behaviors. So I want to ride very high on a beach road. I just want to try out a substance just for the sake of understanding how it feels. So what is the harm in trying even once, just to understand how it feels? So all these greater risk-taking behaviors are mediated by the limbic system, which evolves faster, the 10 to 18-year age spurt. The second half is 18 to 25 years. That is where our front part of the brain, that is the prefrontal cortex, evolves. So that is the brake mechanism. If you conceptualize limbic system as the accelerator in a car, this prefrontal cortex is like the brake. So when an adolescent is driving at a high speed, they don't have the brake to control their impulses, because the prefrontal cortex starts maturing at a later phase, that is at 18 to 25 years of age. So only when that maturation happens, they'll be able to logically understand the consequences of the decision. So if I'm going to take a substance now, what am I going to face? What are the potential consequences? So that thought process happens only a little later. So if you have a car with an accelerator but no brake, then what would be our advice? So drive slow, or better don't drive at all, right? So the similar advice is very crucial for an adolescent. Say no to substances or try to postpone even trying a substance. So it is not that you try once when you are 14, 15 years and then quit it, because your brain is wired differently at that age. So I'm not going to dwell deeply on these topics, but just to understand adolescence, that is again the age where a lot of psychological issues happen: depression, high anxiety, substance abuse, gadget addiction, which has come a big way these days. So depression is not just a normal sadness or a normal emotion we all feel. Depression is only diagnosed when there is a constant low mood, lack of energy levels, feeling drained out, and this mood change is sustained for at least 2-week duration, and it is interfering with the person's academics or occupational functioning or other aspects of his life. We need to understand, as we understood mind is a function of brain, we need to also understand depression is also having a lot of neurobiological and neurotransmitter dysregulation at the brain level. So depression has neuroinflammation, neurotransmitter imbalance, synaptic dysfunction, and impairment in neurogenesis. Excuse me. So how does an adolescent perceive himself? It is like you are viewing the world through a black specs. So the way you see it will be very different. So for an adolescent, it is how they view about themselves, how they view the future, how they view the world. Excuse me. So an adolescent might feel, I am a failure, I'm worthless, I'm not valuable. Or an adolescent might feel, I'm not loved enough by my family or by my peers. Or I may be feeling very hopeless about the future or about how things will go in future. Anxiety in adolescence. So that can be generalized anxiety, that can be social anxiety, which a lot of adolescents struggle with. They are super active in social media, but when it comes to real time, they are not able to connect or maintain an eye contact or converse appropriately to somebody whom they are working alongside. Relationship insecurities, relationship conflicts. So in this era of live-in relationships, what we call a situationship. So there are so many terminologies in the context of relationship itself. So all these things happening, somebody can become more vulnerable to stress. So somebody who's focusing more on the virtual identity, how many likes I have in my Facebook page. So versus how many real-time friends I can really share my stress. So these are subtle aspects, what pushes somebody to a substance. So coming to the topic proper, that is substance abuse, it is so common, so common. So around 13% of people are involved in drug and substance abuse are below 20 years of age. And a recent report which the government submitted to the Supreme Court, it says around 1.6 crore children between 10 to 18. Remember that it is not about 18 to 25, it's 10 to 18 or 10 to 17, that age group. you remember the slide we spoke about, the early limbic system development where they don't have a prefrontal cortex maturing. That is when a lot of children are getting addicted to substances. The earlier the people start using drugs, the greater are their chances of becoming heavily addicted or getting into that loop of addiction. So there are so many drugs in the market, or I mean, in the world of drug abuse or illicit drug trafficking. Opioids are very common. Recently, we had a patient who was abusing Tidal, that is a opioid. So the tablet was crushed and mixed with water and injected and things like that. So a lot of inhalants. So a lot of times they just smell on a lot of inhalants, alcohol, sedatives, sleeping pills. When it is prescribed by a medical practitioner, they can just continue on that medicine on their own. They can self-medicate. Cannabis is very, very commonly abused. Hallucinogens like LSD, MDMA, cocaine, these are hard drugs, but its use is also increasing in this society. So the list is large, so as I already mentioned, but the common ones are tobacco and why would somebody use drugs in their early life? It is very commonly peer influence because our friends use it. They just give you and ask, why don't you try it at least once? Stress and depression, which I already spoke about. Lack of parental support or social systems. If a child says like, I can't really vent out my stress to anybody out there. So my parents are lacking time. I don't have a good friend circle. So this is my only means of coping. Entertainment industry, a lot of times, our heroes or the cinefield portrays using drugs as a cool thing to do. So when you hit somebody, when there's a violent scene, when there's a negotiation that is happening, so often we see some form of substance being given that hero role. Easy access, very, very common. It's all very accessible. We end up doing a lot of awareness talks in schools and colleges, only to understand the substances available in 1 kilometer radius from the educational institute. So what is more important is to have a legal curtail on the accessibility of the drugs. Most importantly, curiosity. So remember the limbic system, which I told you. So it makes you for novelty seeking. I want to understand. I just want to try how it feels like, just like how I go for a roller coaster in a entertainment. I want to just understand how it feels. So just for the curiosity aspect, somebody can abuse drugs early in life and then can get addicted to it. So I don't know how many of you have seen this ad, or I don't know, some of your patients using it. Very, very common. If you ask me, like, what is the most common substance that is used? It is not even alcohol, it is tobacco, and this form of tobacco called Cool Lip. So you get one packet of Cool Lip that has some 30 to 50 pillows. The one on the right side is called a pillow or a pouch. So it contains basically tobacco, that is nicotine, along with a lot of adult aromatic, other adulterants and some of the aroma enhancers, something like that. Very, very common in school children. If you go around a school campus or if you go around somewhere and see some glittering papers, remember that it is nothing else but it is Cool Lip. It is no other candy, it is Cool Lip. What the child does, or the school student or the college student, they do is, they take one pouch and keep it under their upper lip or lower lip, just like how you just park your tobacco or something. And that Cool Lip delivers tobacco and it gives the patient, the person who's abusing it, a high. You may not be able to really understand it looking at them outwardly. You see the person to be calm, subtle, unless you go and trouble them and ask them what it is, where they may end up feeling very aggressive and they may be very offended. So the Cool Lip is one, we call it as a gateway drug meaning it is so easily available. And if one child buys one packet, is only like 30 to 50 rupees. One child buys one, he gets 30 to 50. So he can end up distributing to his friends as well. So they take turns to buy it. So it's very, very common. And this paves the gateway for higher substances also. So what is the impact of substances? So it can cause acute intoxication where you feel the sense of pleasure or the high. You can start abusing it, ending up using harmful use, for example, drunken driving, things like that. Dependence, where you feel, I'll say about the criteria for dependence later. So somebody who's addicted, going to stop the drugs, they may get withdrawal symptoms, not able to sleep well without the drug, cannot manage my routines without the drug. Sometimes it can trigger your neuronal circuits, which can get wired very differently if you are going to use it very early. And psychotic disorders, very common with cannabis. So people can start hallucinating, hearing voices, or feel that others out there are spying on me. I have somebody who's like really targeting me. So psychotic symptoms can emerge. Dementia, very common. One of my colleagues had a child who's 7-year-old who's abusing cool lip so extensively and constantly. There is so much of ventricular dilation. The child is not able to understand. The child who was developmentally normal again regressed back to not talking anything, or the milestones that got achieved again got lost. So we are also really learning the impact. As much substances that are very new in the industry, we do see a lot of impact of these newer substances also. So we need to understand there's a top-down model of impulsivity. Impulsivity is what I already spoke. So I have the accelerator, I don't have the brake. So without any thought process on the consequence, I start abusing or using a drug. It gives me a high. So once I use it, because of the pleasure circuits, I have a tendency to use it again and again and again, and it makes me more addicted to it. And this addiction or procuring the substance becomes my priority. So what started off as an impulsive or a recreational use becomes compulsive. So when it becomes a compulsion to use, I have to use the substance, you get so addicted to it. When you don't use it, there are so much of negative symptoms or withdrawal symptoms. So dependence is diagnosed based on a lot of criteria. We have DSM-5 criteria. So basically, it just means that you take the substance in longer amounts or for larger amounts or for a longer duration. You are trying to cut it down, but you fail miserably. You are spending a lot of time to just ensure you will get the substance for the day. There is so much of craving. You crave, or you are feeling so tempted to use the substance. You are not able to quit it, even though there are problems in your school, college, or in your workplace. So there is significant impairment. So all these things indicate that the person is what started off as a recreational use is going to a dependence. So as I already mentioned, somebody can get into a substance-induced psychosis where they have a lot of hallucinations, thought disturbances. The way I perceive my environment, my mood becomes altered. Substances can induce depression. It can predispose individuals to suicide. So I'm depressed, I'm taking alcohol, in a bit of intoxication, I can commit a suicidal act. So a lot of drugs can induce psychosis, as I already mentioned. So it's just a sample where people who abuse alcohol or having alcohol dependence, you can see the amount of ventricular dilation and the memory impairment or the frontal lobe impairment or the shrinkage, which is very common, not necessarily with alcohol, but with a lot of other substances, because all substances get wired through the same pathway. So we need to understand it's not about the individual's willpower or a lack of willpower. It's a very, very biological disorder that we are dealing with. So it's again another thing, the crux of what I'm trying to communicate. So limbic system, the lower order brain wants you to feel good, give it a try. The child in your brain who wants to try out substances. The prefrontal cortex plays a role of a brake in the car which is running at high speed. It controls your impulses, manages your emotions, makes you understand whether I have to use a substance or not use a substance. It is the adult in your brain which really is very, very important to have a control on your drugs. Though non-substance, DSM-5 also incorporates non-substance use disorder now under the spectrum of addiction. So gadget addiction, latest, the CEO of a dating app has told this sentence, if that makes any sense to you. I don't think your brain really knows the difference. It is going to get the same neurochemical hits. If you're going to take a shot of alcohol or a line of cocaine, you're going to check your phone repeatedly for a push notification. So gadget addiction works similarly at par with drug abuse. And needless to mention, adolescents who are playing online with multimodal team, which gives them so much high at par with cocaine. So I just wanted to mention on it. So somebody who starts using gadgets as a means to tackle boredom might feel the high and get addicted to gadgets also. And phone addiction also has an equal consequence at par with substance addiction. So we all know the WHO model of health. There are biological aspects, psychological aspects, and social aspects to health. So why is it important to have this model? Because biologically, somebody can be genetically vulnerable. So somebody whose father is having alcohol dependence, the child is at risk of getting addicted early in life. So there's a lot of genetic vulnerability there. There's a lot of psychological issues like what is your coping skills? What is your social skills? How do you place yourself? What is your identity? The things that I mentioned in the adolescence. And there are a lot of social things also. Our family situations, the school environment, peer pressure, the influence our media has on us. So all these things are interacting very dynamically to push somebody to using a substance or to protect somebody when they are confronting a substance in their life. When do you have to consult or when do you have to refer? So when the symptoms are heavy or when the person is getting into a dependence mode, or when there is significant impairment in functioning, somebody who's abusing a substance but not going to college regularly, there is frequent absenteeism in the workplace. And whom do you have to consult? Generally, mental health professionals are the people who are dealing with substance abuse and the impact. Psychiatrists are the primary people who can do the assessment and do a holistic approach. Psychologists have a role to play in terms of improving the client's motivation to quit. And once the patient is out of the withdrawal and the withdrawal is treated, they have to motivate the client to remain abstinent. Counselors do play a role. So the treatment options are many and it is specific to what kind of substance they are using. Medications play a very important role, basically in two angles. One is when they are acutely stopping the substance, they may have withdrawal symptoms. For example, somebody who's having alcohol dependence, when they are stopping using alcohol, they may have a lot of disturbances like tremors, not able to sleep, delirium. So we have to give time and benzodiazepines to tackle the withdrawal. The second half is the maintenance part where you are going to put them on medications which are having anti-craving. Drugs like acamprol or disulfiram, baclofen. There are drugs, naltrexone for opioid substitution. So there are drugs which work specific for that substance. Counseling and talk therapies, lifestyle modification, sleep hygiene, rehabilitation is very, very important. What is more important is it's not only the psychiatrist's job as some speaker or sir mentioned in the introduction. We all have a role to play as a society. So if we are going to treat cool lip addiction and send him back to the same school, and that cool lip is going to get sold in that same place, it's very difficult for the boy to quit. So it's a multimodal approach where it involves doctors, it involves psychologists or counselors, it involves the people, authorities, school principal or the authorities who are concerned. It involves the parental support, family monitoring systems. It involves the society in the overall perspective. So if you feel stressed, we have to spell it backwards. So stressed, if you spell it backwards, translates into deserts. So what is more important is International Day Against Drug Abuse and Trafficking, which falls on 26th of June. This year's theme is, the evidence is very clear. Invest in prevention. So we are investing so much in running de-addiction centers, treating them and forcibly admitting them. But we have to really invest in prevention. That's why it's very important. We understand why this talk is of much relevance now, because somebody who can prevent using a substance or avoid using a substance, that is the way to go. That is the only way to go. So how are we going to enable an adolescent avoid a substance? So World Health Organization lists a lot of life skills which can empower them for taking a right decision when they are having an access to drugs early in life. So the 10 top life skills or the crucial life skills which are applicable to each one of us are self-awareness, our strength and weakness, empathy and interpersonal relationships, effective communication, critical thinking. If somebody offers you a substance, are you assertive enough to say, no, I will not use it? Creative thinking, problem solving. When I'm confronted with a lot of challenges in my life, how am I going to solve these problems without getting into unhealthy coping strategies like substances? Decision making, arriving at the right decision. How am I going to cope up with my emotions, cope up with my stress? So each of these life skills are a session on its own, but it is very important to empower adolescents on each of these life skills so that we are able to prevent them from using a substance. So best life is possible when we change the behavior or their awareness, their emotional coping skills or the resilience, their lifestyles and situations, that is the access to a drug, the means of seeking help at the earliest, change their thinking pattern that drugs are no longer cool and they cannot really help them lead a healthy life. So I would like to end my talk with this pledge that as an individual, we pledge that I live a drug-free future. I'll show my friends that drug-free life is more fun and we shouldn't really cover up drug abuse under any of the other rational things. And I will seek information and assistance when I am dealing with problems pertaining to my drug abuse. I'll be honest and open with my near and dear ones, my parents and support systems. And I'll work as a team. I have to liaise with a lot of policy makers or decision makers so that drugs together, we are working towards a drug-free community. So we need to say yes to life and no to drugs. So thank you once again for this wonderful opportunity. And it's a pleasure to be able to speak on this topic today. Thank you so much.
Thank you, Dr. Ramya, for your excellent talk. In short, you have covered everything regarding the psychosocial development, the various substance, its dependency, its impact, side effects, and the treatment modality, and also the alternate therapy. It was excellent. Now over to questions. I'll just read out the question. Ramya, you can answer the questions.
Sure, ma'am.
Is outcome of drug abuse is better in men or women?
The outcome of drug abuse, my answer is two-pronged. One is generally the substance use and the impact of it is higher in men because of the more common prevalence in men. But today, there is almost a rising trend in women also. If you are going to speak purely as a biological person or as doctors, the impact substances have in women is much far-fetched than the impact in men. And women, if they are going to use drugs for abusing or as a means of coping or whatever it is, they find it more difficult to quit. Because many times, men abusing a drug will be well known to the women, but women abusing drugs may not be known by the spouse or by the brother or the parents in the family. Because under the cover use is very common in men. I have had housewives who like travel 3-4 kilometers to have a smoke. Again, they come back. The husband is blissfully unaware that what the housewife is actually doing. So like biologically, if you go by the biology alone, their neurocircuitry is very different and it is very difficult to treat addiction in women. That's why whenever we come across substance use in whatever form in women, we spend a good amount of time in psychoeducating saying that they are biologically different. It has nothing to do with equality or things like that.
I would like to add, is it over, Ramya?
Yes, ma'am.
Hello, Dr. Ramya?
Yes, madam. You can add.
I would just like to add one more point on your statement. That is, prevalence of drug abuse is more in men, but the affection rate is more in women. That is because of the vulnerability to addiction and brain atrophy develops more rapidly in women. So abuse rate is more in men and affection rate is more in women. And the next question, how common drug-induced psychosis should we inform the patient before prescription?
Drug-induced meaning medication drugs, madam.
How common drug-induced psychosis should we inform the patient before prescription?
Drug-induced psychosis, like for drugs, like, I mean, substances, if that question is pertinent to substances, cannabis is one very, very common precipitating factor of psychosis in vulnerable adolescent. And common drugs like steroids or immunosuppressants and drugs which are dopaminergic agonists like Parkinson's disease, where you give syndopa for a patient and all, it can trigger psychosis. So when you are using drugs, psychotic symptoms are a hyperdopaminergic state. So whenever a drug is going to increase your dopamine levels in the system, the person is at risk for psychosis. So drugs like steroids or drugs like which are dopamine agonists or drugs like used for Parkinson's. So these drugs can induce psychosis in vulnerable population. Sometimes the person is going to have another substance use disorder and also some drugs which can potentiate psychosis. They are more at risk of developing psychotic symptoms. So we have to really psychoeducate them on what psychotic symptoms are, and they have to seek the psychiatrist help when they have such symptoms.
I would like to add one more point. Drug-induced psychosis is more common in amphetamines, 5 to 100%, cannabis 12 to 80%, than cocaine and opioids.
True.
Next question. If drug abuse and psychotic person commit any murder, are they exempted from legal issues?
No, they are not exempted from legal issue because having it as a part of the drug abuse, it is very similar to drunken driving. You drink, you drive, and you hit somebody. You having a high alcohol in your system doesn't give you any defense. Similarly, though psychotic symptoms in the context of non-drug abuse, if the person is having a psychotic symptom, then it warrants a discussion further. But if it can be clearly proven that person was on a substance and that has caused reasonable impairment in the logical thinking, because of which a murder or a crime happened, that will not serve any defense for that individual.
Yes, Dr. Ramya rightly said. So, intoxicated person, most probably they'll be in a delirious state, and where the cognitive level, there is a fluctuation. What they are doing, they are not aware of what they are doing. So, the act done according to the McNaughton's rule, the act done is right or wrong. So, they are not able to judge the incident or the event. And then the psychotic person already, they lose insight. So even they are not having insight, they are not in touch with reality. So they do not judge whether the act was done was right or wrong.
True,
so in both the cases, if the patient is in reality, though with a delusion or hallucination, if the patient has a insight is retained, and also in drug abuse, if the insight is retained and patient has a not in a delirious state, then while the murder committed is right, were they in position to know whether judge it's right or wrong? Then if he is aware that what he has done is right, then he is accountable for punishment, he is liable for punishment. If he is not in a position to stand for trial, that is if he what the committed crime is right or wrong at the time of crime, then he is likely to go for a treatment. Am I right, Dr. Ramya?
Correct, madam. Correct, madam. Yeah.
So next question, what is the prognosis of early substance use disorders?
The prognosis is guarded, or sometimes despite our best treatment, the neuronal circuits can never reach a state of normalcy. So very similar to if you have a seizure disorder which is untreated in early childhood, suddenly the child, you start treating, whatever scarring or the neuronal toxicity that has happened might be reversible, might not be reversible, making the condition refractory. Very similar way, earlier the substance use is initiated, earlier the child is going to try a substance knowingly or unknowingly, greater is the impact and poorer is the prognosis. Anything else, madam?
Okay. Thank you, Dr. Ramya.
Madam, regarding the substances which are being used by the drug addicts and all those things, even for us, the knowledge is very, very less, madam.
True,
actually, you may be knowing, as psychiatrists, you might have seen in your institutes, or they might have shown you in the practical classes and all those things. But we don't know anything about it, because நீங்க இப்ப இந்த மிட்டாய் அந்த பாக்கெட் பவுச் காமிச்சீங்களா, அது கூட நாங்க பார்த்தது இல்ல. இப்போ
சார் நீங்க ரோட்லயே பாருங்க சார், இருக்கும் சிக்னல்ல எல்லாம்.
அது என்ன பேர் மேடம்? அது
கூல் லிப். சும்மா போய் டீ கடையில கேட்டு பாத்தீங்கனாலே
அதான் மேடம் கூல் லிப் அந்த மாதிரி தான் மேடம். நான் என்ன சொல்றேன்னா, நீங்க இந்த மாதிரி டாக்ல வந்து என்ன வந்து நாங்க காமிக்கலனா, நீங்க வந்து ஒர்க் ஷாப் மாதிரி you have to show இது வந்து cocaine sir, இது வந்து இதுங்க sir, you have to show, then only everyone will know what by seeing all these things. What runs in my mind is we should conduct a workshop from the IMA AMS stating that what are all the drugs that are available and how it is available to the community. Then only we will be able to know how to avoid it.
Right, exactly.
அவங்க வந்து அடிக்ட்ஸ் ஆகிறது அதெல்லாம் வேற விஷயம் மேடம். அது வந்து அவங்க பழக்கம், அது வந்து மாற்ற முடியாது, அது வந்து ஏதோ ஒரு காரணத்தினால பழக்கத்துக்கு போயிடுறாங்க. பட் என்னென்ன பொருள் இருக்குன்னு தெரியல. இப்போ வந்து ஸ்கூல்ஸ் கிட்டே வந்து பாத்தீங்கன்னா ஏதோ மிட்டாய் ஏதோ விற்கிறாங்கன்னு சொல்றாங்க, அதெல்லாம் நமக்கு தெரியலைங்க. ஸ்கூல்ஸ் கிட்டே விக்கிறாங்க.
ஸ்கூல் மிட்டாய் தான் சார் கூல் லிப்.
ஸ்கூல்ல வேற ஏதாவது கூட இருக்குதுன்னு சொன்னாங்க.
இருக்கு சார், இருக்கு நிறைய இருக்கு.
எல்லா மிட்டாயும் அங்க வாங்கிட்டு போய் அங்க சாப்பிட்டு அப்படியே உட்காந்து தூங்கிட்டு இருக்காங்க. அப்புறம் இந்த மாதிரி இரிட்டபிள் ஆகுறாங்க. Something people were telling.
True sir. For lack of time, I didn't dwell on each of the substances, sir.
அதனால வந்து நம்ம வந்து we should create a small. நான் வந்து I request our secretary also and also our joint secretary.
Yes sir.
Sir also. We will on the drug trafficking day, we will conduct a small workshop like in all the branches possible, if possible. We will conduct a small workshop by the psychiatrist of that region. After IMA, we'll conduct a small workshop on that. What are all the available products? அப்படின்னு சொல்லிட்டு நம்ம ஒன்று கிரியேட் பண்ணலான்னு பிளான் பண்ணிருக்கேன். So that our members will know என்ன நடக்குது அப்படிங்கிறது தெரியும். ஏன்னா நமக்கே வந்து என்ன ப்ராடக்ட்ஸ் இருக்குன்னு தெரியல. நம்ம ப்ராடக்ட்ஸ் என்னன்னு தெரிஞ்சாதானே வந்து நம்ம வந்து ஸ்டாப் பண்ண முடியும். தட் இஸ் த மெயின் திங். ஏன்னா ரொம்ப ப்ராடக்ட்ஸ் அவைலபிளுங்க சார். ஸோ அதை வந்து நம்ம எப்படின்னு கண்டுபிடிக்கிறது, நாம வந்து அதுல பார்த்தா தெரியும். உங்களுக்கு தெரியுமா என்ன எனக்கு தெரியாது
சார். எங்களுக்குமே we are also learning a lot sir. ஏன்னா இப்போ இந்த February 14th அப்புறம் மார்ச்ல I had a patient who came with a kit, Valentine's Day kit. It was gifted by her lover to her, which came by courier, which contained cannabis in the purest form, which is supposed to be like when the aroma oil mari vittu room la vaporize panni vape pandra mari. First time I am seeing that it is available as a Valentine's Day gift. So it's like, I mean, we are also getting to understand a lot of things, but I mean, it's like, I mean, ever evolving or ever growing industry. As you rightly mentioned, we need to be more aware, sir.
அதாவது நமக்கு முதல்ல தெரிஞ்சாதான் நம்ம வந்து பேஷண்ட்ஸை வந்து எப்படி பார்க்க முடியும். சைக்கியாட்ரிஸ்டுக்கு தெரிஞ்சாலும் கூட நம்ம வந்து எல்லாருமே மோஸ்ட் ஆஃப் த பீப்புள் ஆர் பிராக்டிஷனர்ஸ்க்கு ஓரளவுக்கு தெரிஞ்சாலும் அவங்களை பார்த்து கண்டுபிடிச்சிடலாம். ஸோ தட் இஸ் த மெயின் திங். ஸோ இந்த ட்ரக் டிராஃபிக்கிங் டேல வந்து we will try to do something. செந்தில் சார் அண்ட் ஜெயராமன் சார் we will plan something so that இது வந்து அவேர்னஸ் வந்து நல்ல வைட் ஸ்ப்ரெட்டை கொண்டு போகலாம் சார். சும்மா வந்து சிம்பிளா வந்து ஏதாவது வாக்கத்தான் நடத்தணும், இதை நடத்தணும், அதை நடத்தணுங்கிறத விட we will spread a message like a fire. We will show what are all the products available. அந்தந்த ஏரியால இருக்கிற ஒரு அட்லீஸ்ட் இப்போ வந்து ஒரு சென்னையில நீங்க இன்சார்ஜ் எடுத்துட்டு ஒரு இடத்துல நடத்துறது, நீங்க திருப்பூர்ல, நான் மதுரை, கோயம்புத்தூர்ல, அந்த மாதிரி we will try to do it like that. So that is my inference from this session. So it was an exhaustive lecture and they give a lot of points about all the products and all those things. Very nice. Thank you, madam.
Thank you, sir. Thanks for your time.
Any other question in the chat box?
There are some candy. One question. There are some candy or chocolate-like things. Please tell us the common names, madam.
Common names நமக்கு வந்து ecstasy, அப்புறம் வந்து இல்லோ, ecstasy, MDMA பேர் வந்து ecstasy, so ecstasy drug of ecstasy ன்னு சொல்லுவாங்க. ecstasy, அப்புறம் வந்து bliss, ecstasy, அப்புறம் வந்து bliss, ecstasy, அப்புறம் வந்து இது தலகாணி. cool lip is never called as cool lip, it's called as தலகாணி only. தலகாணி இருக்கா, like that only they ask. So மத்தபடி that is called a pillow, sir. That one looks like a pillow, and the kutti white color. So school children call it as talagani. They don't call as cool lip. So so it's all like very region specific, or I mean they use it amongst themselves.
Talagani, cool lip, அப்புறம் வேற என்ன சொன்னீங்க?
Ecstasy, sir. MDMA, ecstasy, bliss and in the அப்புறம் வந்து stamp is LSD. LSD is available as patch, nicotine patch மாதிரி. அதெல்லாம் ஹை அண்ட் ட்ரக்ஸ். இட்ஸ் குட்டி ஸ்டாம்ப் மாதிரி தான் இருக்கும். அது ஒட்டினா ஸ்கின்லேயே டிரான்ஸ்டர்மலா அது போயிடும். லைசர்ஜிக் ஆசிட் அமைட்னு சொல்லிட்டு எல்எஸ்டி ஹாலுசினோஜன் அது. ஸோ அது ஸ்டாம்ப் மாதிரி இருக்கும். ஸோ தீஸ் ஆர் தி காமன் ஒன்ஸ் சார். பட் ஐ மீன் தே மே ஹேவ் அ லாட் ஆஃப் கோட் வேர்ட்ஸ் கைண்ட் ஆஃப் திங். அது நம்ம போய் கேட்டால் தான் நமக்கே தெரியும் சார்.
மேடம், உங்களுக்கு இந்த ஸ்கூல் சில்ட்ரன்ஸ் இந்த மாதிரி மெட்டீரியல் யூஸ் பண்ணி எக்ஸ்பீரியன்ஸ் ஏதாவது இருக்குங்களா?
இருக்காங்க சார். நம்ம நிறைய காலேஜ் ஸ்கூல் சில்ட்ரன் காலேஜ் ஸ்டூடெண்ட்ஸ் சார் பேசுவோம். அவங்க கூல் லிப் இஸ் வெரி வெரி காமன் சார். கொஞ்சம் அந்த கிளாஸ்லயே ஒரு ஹை ஆர்டர் ஒருத்தர் 2 பேர் வந்து கொஞ்சம் ஹார்ட் ட்ரக்ஸ்ல இருப்பாங்க. ஸோ தே ஆர் தி மோர் சிவியர் ஒன்ஸ். பட் த காமன் ஒன்ஸ் ஸ்டாண்ட் வித் தி லெவல் ஆஃப் டொபாக்கோ ஆர் ஏர்லி இனிஷியேஷன் ஆஃப் ஆல்கஹால் சார். நம்ம நேஷனல் ஆவரேஜ் ஏஜ் ஆஃப் இனிஷியேட்டிங் ஆல்கஹால் இஸ் 11 years சார். It is not 21 years. 11 years is the national average. And Kerala and Tamil Nadu are little கொஞ்சம் கூட சீக்கிரம் average நம்ம national average.
Below 10.
So I mean, it is very, very rampant, sir. Many a times when children are demanding privacy and we don't have a direct access or understanding of what is happening with the child. I mean, a lot of times it's only when some situation becomes out of hand or something is very explicit that we get a chance to intervene. So, but what is more important is the evidence is clear. Invest in prevention, Madri. We have to prevent to prevent, as sir rightly mentioned, awareness is the key.
There was one question: how common drug-induced psychosis? Should we inform the patient before prescription?
That's fully answered.
Yes, sir. We answered it, I think, sir. We have to inform the patient if we are using drugs which can induce psychosis like steroids or Syndopa or any dopaminergic agonists.
Lot of drugs can cause psychosis, including ATT, INH, isonicotin acid, rarely. So I'm not saying cases INH is psychosis at all. And the second line drugs and all, but they can cause very rarely, but we have to keep in mind that.
Some of the anticonvulsants also used to produce.
Yes, sir.
Like recently there is levetiracetam there.
Levetiracetam varum, sir.
Levetiracetam the latest solitary drug, madam. That is the point.
Levetiracetam can cause behavioral disturbances.
We are afraid of using it.
Psychotic symptoms can happen.
Because also can cause in the long run neuropsychiatric manifestation.
True, sir.
Left and right for allergic rhinitis, anti-allergic treatment. So montelukast and the cetirizine combination. This montelukast in the long run it can cause the neuropsychiatric manifestations. Another 2 weeks, maximum 4 weeks, to stop on. The patient may develop daily night or tablet anti-urticaria, allergic rhinitis. So we have to tell the patient such a way. The 2 weeks, 2 weeks, you must come for a consultation.
அவங்க montelukast எடுத்தாச்சுன்னா அவங்க அடிக்ட் டைம் ஆயிடுறாங்க சார். சில பேரெல்லாம் வந்து சார் அந்த சளி மருந்து கொடுங்க சார். வந்த உடனே முதல் வேலை அது சளி மருந்து கொடுங்க சார். அது கொடுத்தீங்கன்னா நல்லா இருக்கு சார். அதுல நல்லா பழக்கமாயிடுறாங்க. People are telling like that and coming and forward. Okay, sir. I think சொல்லுங்க.
ஜெரவன் சார்.
சொல்லுங்க.
முடிச்சலாமா சார்?
Yeah. If there are no questions, shall we conclude the session, sir?
Yes, sir.
Okay. Thank you very much. We had a wonderful, important sessions. First session is the World Blood Donor Day. So I thank Dr. Indumati, moderator, and Dr. Devi ma'am, a speaker. Had a wonderful discussion on the blood donation. So what are the blood products and the transfusion reactions, trolley, a lot of things we have learned. I hope all the delegates learned so many points. The second session to commemorate the International Anti-Drug Abuse Day. It's very, very important. Nowadays, this is a condition epidemic. This is a drug epidemic, like a tobacco epidemic. This is a drug epidemic. Usually youngsters at the age of 11 to 18, teenage groups, they start all the bad habits like tobacco smoking and alcohol, plus the slow kind of this mithai addiction tablet, a lot of things available in that metro cities and other areas and all. So in the urban suburban areas, a lot of cannabinoids and ganja, there are a lot of substances. So our as a medical point of view, we have to promote awareness like this kind of theory and workshop. Our chairman Rajesh Babu said very clearly. So we need to educate our patients with a practical way. So what are substances available? We can conduct a workshop in various places and all. So this way we can update, we can prevent we can avoid all this thing and all. So our aim is to have a drug-free future. This is our motto behind the International Anti-Drug Abuse Day. So we hope all fight against this enemy of this human mankind. So I thank all the leaders of our IMA and all the delegates who are logging in this special webinar of IMA AMS monthly webinar. So I thank you all. I thank you all the technical team and Aravind. So thank you all and all. We'll meet again with very good topics like this, and we'll meet again next month, first Thursday. So thank you all. Have a nice day. So long live IMA AMS. Thank you very much.